in some form of managed care before too long. Now, the counties already have a semi-managed care environment and have been working with that for some time, but we expect that that's going to become a more complete managed care environment before long. So we need to understand that. We need to understand capitation. We need to understand case rates and value-based purchasing. So that's what we've asked Dale to explain so we can understand this better, and it will help us as we think about planning for the next couple of years and what should our new finance structure look like. Now, Dale only has 20 years of history working in this field, so he's still a child yet, but he's getting there. Another 10 years. Dale is a CPA, among other things, but his work really has been focused in behavioral health care systems for quite some years now. He's working with a lot of states. He's also been working in California a huge amount. I keep teasing him he's going to have to move to California pretty soon because so many of our counties, as well as those of us at CIMH and CMHDA and other statewide organizations, keep contracting with him to come do work with us. The great news about that is he really understands very clearly and very concretely how our financing structure works, which is very different because most people coming from another state, we spend at least a day or two just trying to get them grounded a little bit about how financing works in California. But don't need to do that with Dale. He knows it well. And so he's going to walk us through and help us learn and understand these new financing systems. Dale.
You are so lucky that you stayed in this room because, after lunch, getting kind of sleepy and the food rushing to your stomach, and, well, we're going to talk about numbers. Is that like the most exciting thing you've ever heard? Okay, and let's see. At the end of my talk, see all this money in the picture here? There's actually a suitcase that's full of that money out in the lobby, and the person that asked the best question would get the key to that suitcase. So, that's also to say that I'd like to offer the idea that think about my slides as background art, and what I want to do is kind of have a conversation with you about money as opposed to sort of blah, blah, blahing at you for a couple hours. So if you have any questions or comments, I really encourage you to just holler. Let's see, this is being taped, so if you want to holler from your table, I'll just repeat the question so that we can get it on the record. Okay, so I have a not-so-hypothetical question for you, which is, what would you do if you woke up tomorrow and learned that the short-term Medi-Cal and drug Medi-Cal fee-for-service billing system and cost reports had been eliminated? And that they were replaced, funding for your county had been shifted to a capitated or case rate model. So I say not so hypothetical question because, as Sandra said, let's see, this is one of those periods of time where every 5 years they say short-term Medi-Cal is going to go away and be replaced with something else, right? How many times have you heard that? But I think that really changes in the wind, So let's just pretend for a minute that even though we can't predict the future, that's like going to happen soon, and so that we have some sense of urgency, some sense of excitement about the kinds of things I'm talking about. Now, what we have in this country, in California, is like the poster child for this. Is what's called a paying for volume versus paying for value healthcare system. And what I mean by that is money flows based on the number of, let's say in this case, the minutes of short Medi-Cal service that you provide for folks that are in the Medi-Cal system. And And you've probably heard that we spend $2.5 trillion on healthcare in this country, which means that it's more than twice as much as what other countries spend per person. But the problem is there's 30% waste. And so $765 billion a year, this is from a recent report from the Institute of Medicine, is in the form of waste. And it's kind of upsetting to think about how much we waste in the healthcare system. But then again, I'm working with LA, and we had this great sort of interaction where I said, I used to be a preschool teacher. Did anyone know that in the room? And there was this great book that I had that I would read to the kids called "What Good Luck, What Bad Luck," and it went something like this: "What good luck! I won a raffle ticket to go for a ride on an airplane. What bad luck! The engine on the airplane burned out. What good luck! I had a parachute. What bad luck! The parachute didn't open. What good luck! I fell into a bale of hay. What bad luck! There was a needle in the bale of hay." Anyways, because there's so much waste in our system, if you do the right things, this also represents low-hanging fruit. And if you do the right things, we can actually turn what we have now, which is a sick care system, and I'll define that in just a minute, that's a technical term, to a true healthcare system. And so where that waste is, the Institute of Medicine said, unnecessary services, insufficiently delivered services, excess administrative costs, fraud, prices that are too high, missed prevention opportunities. The short story is we only spend half of what we need to on primary care in this country, half, and behavioral health, you may be shocked to hear, is dramatically underfunded. So one of the things that I do is I look at national, state-by-state figures on how much they spend for behavioral health services, and if you take the average of the 10 most well-funded states in the country, California's not on that list. The average is about $4,500 per target client per year. And California is half that. Even with MHSA funding, you're at about $2,200 per target client per year. So you're one of the cases where behavioral health is underfunded. And what happens is the money only starts flowing after we get sick. It doesn't matter whether you're in private insurance or Medicaid or especially uninsured. And so the idea is that if we move to a new payment model, here's the gem. The reason why I'm telling you this story about all this money stuff is that if we move to new payment models and we push the money further upstream into services that actually help keep people healthy, and when people do have chronic health conditions, we help keep them out of the hospital, we just suck a huge amount of money out of the waste, and the idea is we reprogram it, that money we've saved further upstream. So I'm anticipating that behavioral health and primary care, either we're going to totally fail as a country, or your system and the primary care system is actually going to get much more adequately funded. And it may take 5 or 10 or 20 years, but it's coming because the hydraulics are just so clear. We're just stuck in the sick care system. And my hypothesis is the way that we break out of the sick care system is by to care systems we change the payment models. So that's not a very complex idea. So today's agenda is really also not very complex. I want to do a virtual field trip, and I want to go to a handful of states that look like what California mental health system might look like tomorrow. And so that'll be fun, and thus my flying saucer. And then I want to talk about 2 types of payment reform. And you may not be familiar with either of these terms, so we'll have fun with that. And then we're going to dig into the payment models that might be relevant for California mental health, the near-term payment models. Because what I really want to do is I want to leave with, I want to end this session so that you're all feeling like educated, enlightened, and energized. And And if you're not feeling that way at the end of the session, you can have your money back for the whole conference, okay? Just go to Sandra. She's actually got a checkbook ready to write you. No? Okay. The checks will be in the mail. Okay. Yes. Great. Yes, thank you. Thank you. And so, let's see, because let's see, what's this called? A symposium? A forum. This has folks from the substance use disorder community, as well as, I see Victor back there, as well as from the mental health group. Thanks. And this actually is going to make it even more exciting. Thank you. I absolutely will. So let's proceed with my three-part agenda. And let's start in Washington State, where I live. I've lived for 34 years. And what we have in Washington, let's see, the mental health system in this state has a 1915B waiver. The substance use system doesn't. And that waiver is with the federal government that says we waive certain things so that we can do this managed care thing, but it's really a pseudo-managed care thing. But I won't go into trying to define the difference between a managed care thing and a pseudo-managed care thing. But in Washington, there are these things called regional support networks. There are 39 counties in Washington, and there are 11 regional support networks. A regional support network is a Medicaid prepaid inpatient health plan, or a PIP. So in California, there are 58 counties, and there are 57 Medicaid prepaid inpatient health plans. So what that means is that theoretically in California, there are 57 little or big managed care companies that are called the county behavioral health or mental health system that are in charge of running the system, and there's a whole set of federal rules and regulations that govern them. So one of the main things that's different about Washington is we have a regional system, and there really are these 11 regional entities that are kind of like those of you that work for the county that run the system. Now, how the state pays the RSNs is different in Washington than in California. And this is really important. This is one of the most important things I want to sort of describe to you, and I want to make sure that everyone in the room sort of kind of completely understands it. All 11 have been capitated by the state, and I'll define what I mean by that. They receive an actuarially sound per member per month PMPM capitation rate for each enrollee, and the state makes the federal match. So if you're running the San Mateo system or the Butte system or the Solano system or the LA system, you count the number of Medi-Cal enrollees if you were capitated, and you multiply them times a rate per person per month, and that becomes your check. And the check gets written and sent to the bank account of the mental health plan, and that's your budget. And so that's kind of a little different than a short-term medical claiming process where, well, I won't go into details because you know how that works, or a drug Medi-Cal payment model where it's really mostly basically fee-for-service. In addition, Washington it has the option of a 0.1% mental health sales tax, so it kind of looks like not really the millionaire's tax that funds MHSA. But the most important thing here is the capitation payments. And again, I really want to make sure that you understand this. So if you were to say, Dale, what do you think is going to happen with the behavioral health system, the mental health and drug and alcohol system in California, I would say it's going to get capitated at some point in the not too distant future, where what I just said has been happening in Washington since 1993 is going to come to California for both mental health and drug and alcohol. So let's talk about actuarially sound rates, the new math. So Medicaid rates, this is like a simple math problem. They're based on counting So here, okay, so I'm setting, okay, so I'm hired by DHCS to say, how should we go about setting rates? And I say, well, the same way that you do it for the healthcare side. You count the historical services that have been reported, and so you count them, and we'll count them separately from mental health, from drug and alcohol, and then you multiply them by a rate for each service. So if I provided 10 services and the average rate per service was $100, then it would be $1,000. And so just multiply that like times 1 billion and you get the budget for mental health and drug and alcohol. And then you add or subtract adjustments for inflation and expected changes of utilization. So this is what actuaries do. Oh, by the way, I'm going to put these slides on my website. I've already sent them to CMH. I really apologize for not getting them into your packets. But I'll put them on my website tonight, which is djconsult.net, and you can pull them down. And so I'm thinking about drug Medi-Cal now. And I'm going, okay, so we count all the drug Medi-Cal services that have been provided, and then we multiply them times a rate per service. And what we come up with is such a small number that I can sort of fit it between my thumb and my index finger. And what we know is, well, we've been promised by President Obama that the Medicaid parity regulations are coming out in February this month. And when that happens, everything's going to blow up, because what we're going to find is, yes, indeed, California is illegal. Its drug Medi-Cal program is illegal. That may not be the right word. It's not following federal regulations because you're not providing the kind of coverage that the federal parity law says you have to be providing for. And so the adjustment, so if you count the historical services for drug Medi-Cal, the adjustment is going to be like huge, because what you're going to need to spend to not be breaking the law is a lot more on drug Medi-Cal than what you're spending now. That's my read of it, even though we haven't seen the reg yet. But anyways, so there are adjustments that are made for things like that need to be made for things like parity. And then so you do all that simple math, and the rates must be based only on Medicaid services. So if you're, but we know that with short-term Medi-Cal, you can only bill things that are short-term Medi-Cal allowed, so that's pretty simple in California. And must only pay for services to Medicaid beneficiaries, which again is no big deal, because that's how it works in California for both drug Medi-Cal and short-term, the mental health piece. So I want to show you a chart that helps illustrate this a little differently. The headings at the bottom of the page are the RSNs, the mental health, in this case, the mental health plans, and the numbers are the actuarial rates. The average, well, let's see, these are the actuarial rates for one rate category. I'll explain what I mean in just a minute. And what actuaries really do are two things that you may not know. The CMS says, we don't really like it for you to come up with a single actuarial rate for the whole state. So when California moves to a capitation rate for behavioral health, I'm just pretending like I know that that's of course going to happen, the rates aren't going to be the same for every part of the state. And so these represent the different, and the other thing that's important is when actuaries do their number crunching, they create what's called a rate band. And so there's a low and a high. For each of these regions, there's a low, like Chelan Douglas, the first one, it's like $112 to $140 per member per month. Are you translating the picture into my words so you're getting how the capitation rates are? So what the actuaries say is for California to not get busted by the feds, because the feds have to approve all this, it can pay for for region number one, we'll call Chelan Douglas, anywhere between $112 and $140. And so the actuarial study doesn't pick one number, it picks a range. And then what the state and the plans all negotiate is where on that rate band we're going to actually set the rates for. And in Washington, what they did was, listen, can you see the little horizontal line at the bottom of the vertical line? That's like right at the bottom of the rate bands for all the bars. Can you see that? So what the states do, what many states do is they set the rate range, they set the payment rates at the bottom of the rate range. Because remember I said the state's paying the match, the federal match. So they do that so that they don't have to spend money, and because any more money than they have to, and because the actuaries say you can pay anywhere on this range, and you're not going to get busted by the feds, then the feds say, oh, well, you're paying within the rate range, so that's fine as far as we're concerned. So that's kind of like how the process works. And then what happens is each month, okay, so pretend that we're all living in Washington, and I'm just like telling you what you already know. Each month you get a check for the capitation payment, and that becomes your budget to spend on county-delivered programs and organizational providers. And then there's actually another payment that gets added on for admin. Let's see, there's one more slide, and then I want to stop and see how many people have fallen asleep. And I'll tell you that that's a good thing, and I'll explain why in just a minute. And then if anyone has any questions or comments. Now, you may or may not know is that in these states that do capitation rates, it's not, we heard about the rate range, and then I sort of kind of tricked you when I said there's a rate band and you set the rate. There's more than one rate category. So I'm looking at my screen, and I'm seeing disabled adults, non-disabled adults, disabled children, and non-disabled children. So in Washington, there's 4 rate categories. You know, like you have in California, like, I don't know, 17,400 Medicaid aid codes. Okay, so those get bundled. And in Washington, because we have lots of aid codes too, in Washington they got bundled into 4. Disabled adults, non-disabled adults, disabled kids, and non-disabled kids. And so what you see here is there's like 14 of these. This is before some consolidation happened. There's roughly 14 rows, 2, 4, 6, 8, 10, 14. And there's 4 rate categories. And so you can see that for Chelan Douglas, the disabled adult rate is $139.58 for the high end of the range, but only $17.50 for the non-disabled adult, et cetera. So like, who would be more excited about all these different numbers than a CPA and a bunch of mental health policy folks? But this is kind of important, that depending on how many disabled and non-disabled adults and kids that you have in your county, whether you're an organizational provider or the county, whether you're mental health or drug and alcohol, there's different rates for different categories, and the state is the final arbiter of what the rate is for that category, and you can see that there's a square for the high end and a square for the low end. So that's kind of what happens. Now the actuaries do their work. The state theoretically is not supposed to twist the arm of the actuaries to overly influence what their work is. But there's a bunch of really bad jokes about actuaries. Like, how do you define an actuary? I'm really bad at remembering these jokes. It's like someone who, tell me what you want the number to be, and that's what I'll figure out for you. If I told the joke really well, it would have been really funny and also really depressing. So, but the actuary does their thing. The state decides where it wants to set the rates on the range. It goes to CMS. CMS reviews everything and approves it, and then the checks start being cut. That's what could very likely happen for the 58 county mental health and drug and alcohol programs as all this reform stuff unfolds. So let's see. Before people raise their hand, I want to just talk about falling asleep. So, my wife is doing this really interesting course of study. She finished this really interesting course of study. She's a marriage and family therapist where they integrated neuroscience, attachment theory, and traumatology. Isn't that a cool combination if you just think about it? And those neuroscientists, Alan Shore down at UCLA is one of the sort of at the center of this universe. And one of the things that they talk about a lot is things that we read about in the paper, which is right before you're falling asleep, as you're falling asleep, your right brain kicks in and you start doing some of the most creative thinking that's ever possible. And the problem is we forget about it because when we wake up, we don't remember what was going on. So if you start falling asleep now, I'm going to be really happy if you do one thing, which is to have your pad and a pen right next to you. And when you wake up, because I'll tell a joke and everybody will laugh and it'll shock you out of your sleep, ignore what I'm saying for the next couple minutes and try and remember what you were dreaming about. Because I bet it's like way more important than anything that the words I'm telling you, even if it has to do with the talk that we're having. Okay? Is that a deal? Okay. So now questions and comments. Yes? Oh, great. Thanks for going to the mic. Yes, you're on.
So Dale, as you were talking about the rates, and you mentioned the fact that, well, it must be a Medicaid reimbursable service to be included in the calculations. And the concern that I have about this is that, and I think it's a little bit of an expansion of what you're talking about, but there are a lot of things that we do as providers that don't typically fall into the Medicaid rates. And so as those rates get determined, if we come up with a case rate that doesn't include all of that stuff, I'm really concerned about undercutting our rates. And so under the Affordable Care Act, I understand that habilitation is a new category of services that's sort of guaranteed under the Act. And I was wondering if you could just comment on the fact that a lot of the stuff that we do that currently isn't billable under Medicaid might be able to be billed under habilitation, and how do we include that when we're talking about building those rates?
Yeah, that's a great question. Wow.
Do I get the key to the valise?
Yeah.
Okay.
No, we have to wait because someone may ask a better question. That's a great. So there's two answers to your question. The first, I'll wait until I get to Montana and then Oregon, because there's some really cool things happening there that are relevant to this. But I'll go directly. But I'll stay in Washington for the first half of the answer to your question. So what Washington did was when they were making some changes to their let's see. Let me tell you the more sordid story because it's really exciting. I was just going to skim over this. So Washington was using they were getting capitated, and they were using a lot of their money for services to non-Medicaid people and non-Medicaid services. And because there was this little Medicaid director's letter that had been sent out a long time ago that says if you meet all the needs of the Medicaid people and you have money left over, you can use it for these other things. And so they got busted. But the feds, this was before, that letter was written when Bill Clinton was president. And then when not Ronald Reagan, he was before that. Sorry. When George Bush, George Bush II was president, Washington got busted because they were using Medicaid dollars for non-Medicaid stuff. And so they had to pay back like $1 gazillion to the feds. And so they got really serious about your question at that point. They weren't serious about it before. And what they did was they said, we're going to try and rebuild back our Medicaid rates. And what we're going to do is we're going to expand what's called our state plan. we're going to expand the services that we're going to put into the Medicaid system. And so they did things like assertive community treatment hadn't been provided with Medicaid money. They had some pilots. They put it into, they made it part of the state plan. So there were several services that they made part of the state plan that weren't part of the widget counting. So they became part of the adjustment process. So the rule is if you add a new service category to your state plan, then you can do, so I actually did the calculations for the actuaries because they didn't know what to do, what to do about this because they just deal with medical stuff, not mental health back then. And so I computed how much the counties that had ACT programs were spending and turned it into a PMPM, and I said if this was on statewide, it would increase the PMPM by $4 or something like that. It was like $4.35. So if you have a friendly folks at the state that that understand what you just said, and actuaries that understand what you just said, and then you can help them identify what else needs to be counted, then you can actually not just be looking in the rearview mirror only as the numbers get crunched. Did that answer your question? That's the first half. I'll come to the second half when we get to Montana and Oregon. Yes? When you're looking at the historical services, can you count the MediMedis as part of the persons being served? Oh, wow. You just pointed out that I kind of like lied to you. Because I said there were only 4 rate categories. There's actually different rate categories for the dual eligibles for the MediMedis, because what the actuaries do is they say how much Medicaid money was spent on the duals, and so when like if this half of the room were Medi-Cal only and this half of the room were dual eligibles, there'd be PMPM rates for you that would be a lot lower than the PMPM for you because Medicare is paying for 80% of the things that they cover. So that's built into the model too. Yeah, thanks for asking that question, because I love when I lie to people and they catch me. Yes?
The definition of disabled versus non-disabled. This morning when John O'Brien was talking about redefining what a medically frail person is and the AHA and everything, what's the determination of who's in these plans of who's disabled and who's non-disabled?
Yeah, so the question is, when my friend John O'Brien, who left without saying hi, was talking about disabled and non-disabled. He was talking about frail elderly. I wasn't here, so I didn't get to hear. Medically frail folks. And what's the definition of disabled and non-disabled? It's really just the aid categories. So there's, like if you went to the office where people get Medi-Cal eligibility, and it's in this case, it's basically people. For adults, it's people that are on SSI, and for kids, I can't remember what the definition is, but it's broader than that.
So the follow-up was that tantalizing little thing that John said that they're reviewing to see if substance use disorders could be considered under medically frail, and since currently under Social Security, addiction doesn't qualify for disability, do I see a glimmer of hope down the road here, possibly, or am I deluding myself?
Oh, so what John said is that substance use disorders people with substance use disorders could qualify as medically frail, and it's possible that the folks in Chelan could get $139 instead of $17 per member per month for those folks. So let's see. Oh, wow. I'm going to answer your question in a totally unexpected way. But first, I'll answer it straight. I'm not holding my breath that folks with substance use disorders are going to get a Medi-Cal aid category called disabled that allow them to get $139. But there's all these folks that are coming into Medi-Cal expansion. a lot of them, but not all of them, are in the LIP that's rolling out in the counties that are in there that aren't able to get on Medi-Cal because they have a substance use disorder only. And they're going to roll into the Medi-Cal expansion population. And there's going to be a new column called Medi-Cal expansion. It's going to be different rates than the 4 that you see on the screen. And the Medi-Cal expansion is going to be computed, the actuaries are going to compute those rates. And those folks, what we know about those folks is they're more complicated and costly than the TANF population, the kids and moms on welfare, but they're less complicated and costly than the disabled, the people that are on SSI that are disabled. And we need to really, so there's going to be a rate for those folks that'll probably be in between. And here's the interesting thing I wanted to say about your question. As long as they don't become physically disabled, the feds will pay 100%, and then coming down to 90%. Because, the expansion population, if this is getting really esoteric, just throw something at me. The expansion population is the feds are paying 100%, no less than 90% by 2019. Because here's the deal. If I moved to California and immediately got a drinking problem because of moving here, my body wouldn't fall apart overnight. It's going to take a while. And as long as, and I'm poor, as long as my body hasn't fallen apart yet, you will get 100% paid for by the feds. I'll just call it 100% so I don't keep saying 90 to 100. But the moment my body falls apart and I become physically disabled for physical reasons, I shift aid category over to the disabled side, and the feds only pay 50%. Did you hear what I just said? So in California, if you do a crappy job addressing the drug and alcohol needs of the people that live here that are coming on to Medi-Cal expansion, such that their bodies fall apart, which will eventually happen, and they become disabled, the state will lose a whole lot of federal matching dollars because they'll go from being 90% covered to 50% covered. Have you talked about that yet? Okay, so this is a really, really big deal. I'm glad Victor walked in and he just missed what I said, because you can just tell him, Dale, you got to make sure that you heard what Dale just said. See, he's asking. Okay, so sorry. So the reason why I'm going off on that little tangent is because if California doesn't do a great job tackling the substance use disorder, then all these adults are going to their bodies are going to fall apart, and they have Medi-Cal just because they're poor. And anyways, you're going to lose a lot of money. There's an opportunity. You can go 10, 15, 20 years downstream, and you go, oh my gosh, Washington actually calculated what the dollar amount was. It was a really big number.
Same would be true for pending SSI. And one of the questions that we have in our county is, in looking at that, given that when SSI is granted, it often goes retro and we get Medi-Cal retroactively, if there's a pending SSI app, do we know if they will automatically not be allowed to be considered in this newly covered group?
See, that's a technical question that has a very clear yes or no answer. The question was, okay, so I moved to California, and my body fell apart in Washington because my drinking problem started 5 years ago, and I have a pending SSI application. The question is, when January 2014 happens, Do I become an expansion person where you get 100%, or do I become a 50% match person? And I think it's the latter, but I could be wrong. But I'm pretty sure it's the latter, and I think that's what I've read, that's how it's going to play out. But don't take that to the, well, it's the opposite of the bank. Don't take that to the poorhouse yet. We'll take a couple more questions, and then I'm going to move to whatever the next state is.
I'm concerned about the drug Medi-Cal benefits in California, which have been used in the SUD field only, and how very, very limited they are, and that taking into account completely inadequate benefits will make the actuarial rate extremely distorted. And we're trying to get the word out, but everybody is holding on to that drug Medi-Cal because it's cheap. And it's going to be a tremendous disservice in the state of California, particularly if the actuaries aren't really apprised and aware of the distortion.
So what's going to happen when the federal Medicaid parity regs come out is the, let's see, the elephant, the cover, how do I want to say this? The blanket that's been covering the elephant in the living room that everybody's pretending it isn't there is going to get pulled off, and this is going to be front and center. And I don't know how it's going to play out, because the counties, as long as you're, stuck in realignment 2, the counties have a lot of skin in the game. They're not any more interested in tackling this problem. Am I being politically incorrect right now? Than the state is. So this is a huge deal. But I think that the feds are going to bust you if you don't fix it. So that's what I think is going to happen. Yeah.
What do you think the impact would be for capitation with county in California, contract with CBOs, how will that impact the contract?
So if the county, what would be the impact? So pretend that I'm a organizational provider, or a community-based organization that's a nonprofit or a for-profit that has a contract with the county, and capitation rates come. What will be the impact on that? That's such an exciting question that I have I have 2 chapters on it. So I'll give you the short version, which is that if the county, that the Medicaid health plans, which are the counties, will be freed up to work with the CBOs to come up with alternative payment arrangements that help move from paying for volume to paying for value. And if it's done right, it will just work way, way better than how it's working now. But I'm going to go into detail about that. Okay, so I see that there's half the people in the room don't have their pads and their pens within 6 inches of their writing hand, so make sure you do that when you fall asleep. Okay, so let's see, there's something else that kind of gets to your question on this next slide. Counties have, I already said this about the sales tax. Oh, and just to explain a couple more differences, very few providers are county-run programs. Almost everybody that works providing service, mental health and drug and alcohol services in Washington State are nonprofit or for-profit organizational providers. But there are 3 payment methods from the RSNs to the providers that they're using, and this gets to your question. In King County, which is where Seattle is, they're not doing fee-for-service, they're doing case rates. There's a few counties that are doing fee-for-service, but they're moving away from that because they're moving to pay for volume, and we'll talk about value, we'll talk about that later. And then subcapitation, some of the organizational providers are paid on a subcapitated basis, and some of the other RSNs. And I'm going to define case rate and capitation in such a way that you'll be completely clear beyond any shadow of a doubt what that means and how it's relevant, how it might work for you, but I'll do that in a little bit. Okay, so let's go to Michigan. That was the longest part of the field trip because everything else is just, there's a few little tidbits I want to put out. And since I grew up in Michigan, I thought we'd go there next. There were 18 Medicaid behavioral health plans, all capitated per member per month, just like I was describing with Washington. But in Michigan, what's interesting is they have this thing called a combo 1915 BC waiver. Aren't those terms like so descriptive? And what it does is it smushes together mental health, alcohol and drug, and developmental disabilities. So when I talk about capitation payments, I was just talking about mental health in Washington, but that's not the future. The future looks more like Michigan, where at least mental health and drug and alcohol get smushed together into capitated rates. And in Michigan and North Carolina, they've rolled in developmental disabilities. And so that's an important little tidbit to know. And just FYI, the state has said 18 is too many, and so they're moving it to 10 regional entities. Has the state ever said to you 57 mental health plans is too many in California? They probably don't even know that there are 57 mental health plans. The people that knew that retired like a couple years ago. I'm not impugning the intelligence of the folks at DHCS by any stretch of the imagination. I just know how busy they are getting ready for healthcare reform that it's kind of hard. I'm thinking it's kind of hard for you to get, there's not enough oxygen in the room for them to think about mental health and drug and alcohol right now. Is that kind of sort of accurate, Sandra? Yeah. Okay. Yes, definitely yes. And and in Michigan, what's interesting about Michigan is that there's a grassroots, not a state-driven effort underway to create a 21-county behavioral health plan. So in central Michigan around Lansing, there are 21 counties that are coming together and saying, we can actually have a lot more clout and be able to run this thing better if we self-organize into a regional PHP that's large enough so that we have some clout. But let's see, that's like never going to happen in California. Well, let's see, CMSP, you've got CMSP. Has anyone ever talked, besides me, about the county mental health or behavioral health departments in the small counties creating a regional Medicaid plan? Yes? Great idea. But I people that look at California, they just go, did you guys pass the medical marijuana law 20 years ago? Like we passed in Washington just last year, around the fact that you have these 57 plans. It doesn't make, I know it makes sense to all of you, but it doesn't make sense to anyone anywhere else in the country. I don't have opinions about things, do I? Okay, so let's go on to Missouri. I want to point out another little thing that's totally different than everything that I've been talking about so far, which is there's this thing called Section 2703 of the Act that allows states to amend their Medicaid state plan to provide health care homes for enrollees with chronic conditions. And a chronic condition is defined, and to be eligible for the Federal Affordable Care Act 2703, some of you know this, you have to have 2 chronic medical conditions, and there's sort of a list, or a medical condition or a mental health or drug and alcohol disorder, or a serious mental illness or a serious substance use disorder. So if you have just a serious mental illness or serious substance use disorder, you could create these things called health homes. And here's the deal. You get 90% match for 2 years to fund these health homes. And so basically what you do, if you do the math on the 90% math, if you have $100 of local money, $100 of federal match, that's $200, 50-50. That the 200 turns into $1,000 because the way the 90-10 math works for 2 years. So what they're doing in Missouri is they said, we're going to do that. And they created 2 health homes, one for primary care clinics. It's the first state to do this. And one for community mental health center healthcare homes. Do people know about this? So some of you do. This is like so incredibly exciting. And what they've done is I'll focus in on the community mental health center health home. What they've done is they said, we're going to turn the 26, there's only 26 community mental health centers in Missouri. There's like that many within a mile of where I was at in Los Angeles earlier this week. But anyways, the 26 mental health centers are being turned into healthcare homes. And what they're doing is, in the coming months, my agency will be applying with the state to be a health care home provider. I'm going to read this whole thing. We will manage the full array of physical health needs in addition to behavioral health care needs and needed long-term care community services and support social services and family services for individuals enrolled in our healthcare home. So what they're doing is they're getting paid not to provide primary care, but to manage a care plan that addresses the whole health of the people, of their clients. And so here's who's on the team. There's these community psych rehab teams that already have case managers, basically, and there's some physician, medical doctor time that's being funded with this new money, and enhanced health coach training you can see for community support specialists. The community support specialists are basically the bachelor's level and peer level folks, and then additional nurse care managers. So that they're using this money to bring some medical staff in so that they can put together care plans to wrap care around other clients that have complicated health conditions. And and then what they're doing is they're creating relationships with primary care clinics. Some cases they're embedding a primary care clinic in their centers, but in most they're not. And so the equivalent of your system is turning from being, my organization helps people who have a mental health or drug and alcohol disorder manage their drug disorder and mental health disorder and move towards recovery, to my organization addresses the whole health, thinks about the whole health and addresses the whole health of folks who live in my community that have behavioral health disorders. You see the distinction here? This is a really big deal. This is the future of behavioral health. Let's see, if I were to get really grandiose and predictive, I would say that if you're providing community mental health services and you're not doing this within 5 years, you're going to be disrupted. But I wouldn't say that because that's grandiose. The behavioral health homes will be paid here's that word again, a subcapitation payment to fund the additional staff and additional tasks. So there's new money that's coming from the feds for 2 years to fund this. The idea is that they'll be successful enough at lowering the healthcare costs that the state will continue funding them these positions and this extra cost out of the healthcare dollars, not the mental health care or drug and alcohol dollars. Okay, so really quick trip to Montana, and then I think we go to Oregon, where the most exciting thing in the country is happening. So what they're doing in Montana, of all places, is this thing with home and community-based services. And so, as it says here, health reform makes improvements to this Medicaid option that began in 2005. It's called a 1915 I waiver. And it allows states to offer other services that aren't normally billable to Medicaid or Medi-Cal. So there are PACE programs, and there are programs for folks with developmental disabilities where you can buy things like housing and supports. Well, let's look at the list. So 1915 I waiver allows a mental health system to use Medicaid money to pay for things that you guys aren't allowed to pay for now. And so the examples, you have to pick a targeted population like youth with serious emotional disturbances or adults with serious mental illnesses. It just can't be anybody in Medi-Cal. So I just wanted to point out a couple things that are in here. It will pay for peer-to-peer services, consultative clinical and therapeutic services. So when like doctors talk to psychiatrists, it pays for that. And it pays for things like food, monthly rent, regular utility charges, household appliances, automobile repairs, insurance. Okay, so let me just say that you guys are doing really great stuff on this list with MHSA funding, right? So if you had a 1915 I waiver and you said for the folks that have serious mental illnesses or serious emotional disturbances, the feds will pay for half of it, then we free up half of our MHSA dollars to do other cool things with. You see what I'm saying about this? So this is an option that's available to you like as of a couple years ago. Well, it got beefed up in the Affordable Care Act. It's been around since 2005. Has anyone talked about any 1915 I waivers for mental health folks? Steve? In yesterday's adult system of care meeting, you were talking about, were you saying good things about it? Oh, Alameda County did a presentation focusing on employment. Rusty, you were going to say something.
Well, we've talked about it among the contracting associations. We've been looking for this, what Montana's now doing for years, thinking because our conversations with the people at CMS were to use 1959 to take our full service partnerships and get federal match for everything we do. And we knew that we couldn't be the first state to do it because we're so big. So we're waiting for some other state to do it, and you just showed us how Montana's done it.
Great, so you've been having conversations about 1915I, but you didn't want to be the first state to do it because you were so big, and they probably would say, forget it.
Not only that, the people that I talked to at Health Services, just were skeptical that you actually...
Oh yeah, the Health Services was skeptical.
They were skeptical and didn't want to pursue it. And also, as Don is skeptical. Don changed it. But I think this proves that this is doable.
Yeah. Did anyone happen to read the article in the New York Times about, like when I think of Montana, I think of Wyoming, and I think of like red states, and how there's all these young people in Montana that are becoming like really liberal. Some people read that article? Yeah, it really blew me away. I mean, it's just the demographics are really changing. Salt Lake City votes consistently Democratic, yeah. Yeah. Okay, so let's see. So now I got to add in Utah to my little example here. Thanks, Roy. Okay, so let's go to Oregon. Just a couple more minutes, and then we're going to shift into the really exciting stuff, which are the numbers. Let's see. We're going to go till, we were supposed to go till 3 o'clock, 3:15. We pushed it back a little bit. Okay. So Oregon, oh my gosh, do people know what's going on in Oregon? It's like right across the border, at least for some of you that live in the north part of this, the 100 people that live near the border in California. Okay, so here's what's happening. Governor Kitzauber, was the governor like in the 90s, and he's an emergency room doc, and he started the Oregon Health Plan. Do you remember the Oregon Health Plan where they did this thing where they looked at all the conditions and they looked at all the treatments, and they said, oh my gosh, Medicaid is paying for all these services that are proven not to help people who are in their end stages of life. And so they had this statewide discussion, and they decided as a community of citizens of Oregon that they were going to stop paying for treatments for people that had a terminal illness that aren't proven to work, and use that money to expand Medicaid. This is the predecessor of death panels, right? But they increased their Medi-Cal rolls by 50% by doing this. This was a huge thing. So anyways, he came back as governor in 2010 with the goal of finishing his work on fixing the healthcare system. So he has this idea that he got a bipartisan support in the legislature, Republicans and Democrats. It's gone into effect now. It's called a new thing that you've never heard of before, called a coordinated care organization. And what it is it's a community-based and governed organization. I'll paint a few brushstrokes about it. It's a hybrid of a health plan and an ACO that includes medical, behavioral health, dental health, public health, social services, housing, and more. So here's what they did. And it's the next slide that's the money part that this is the lead up to. What they did was they said, we're going to blow up the health plans, and we're going to blow up the mental health plans that those of you that work for the county run. We're going to blow them up. And we're going to create a new entity that combines everything, that has a community board, and communities around the state would come together as a single county or multiple counties and submit an application to become a CCO to manage the whole schmear. And what we're going to do is we're going to move away from capitation rates. This is the real kicker here. This has never happened before. Oregon is the first state that's done something called moving from actuarially sound capitation rates to a global budget. So let's look at what I mean by that. Global budgets to local communities to improve health and improve care, resulting in a reduction in the rate of growth in Medicaid spending. I'll define what a global budget is in a minute, but this is the premise. The CCOs are expected to implement alternative payment models. I'll say more about what I mean about that. The feds are providing $1.9 billion of seed money over 5 years, which for Oregon is a really large amount of money. And in return, they expect, so the feds are saying, we'll give you $1.9 billion if you slow the rate of growth by 2%. Okay, so here's how it works. Because I'm working with 4 of the CCOs. They got some actuaries, and the actuaries pulled together everything that they were spending, the widget counting, that's how the actuary process works, and then they pulled together everything else that they're spending money on that isn't counted by widgets, like the things that you were talking about that aren't in the plan, that got built into the budget. And they said, okay, so here's how much money we're spending in total. Now we're going to give that money to each CCO that meets the definition of a community board and is going to fix the healthcare system in the local community. And you have to keep submitting encounter data, claims data, but we're not going to pay you anymore on those encounter data. What we're going to do is let you use that money however you want to help improve the health of the population. So the example the governor uses is there's an elderly person in their home who's at risk going into a nursing home and her air conditioner breaks. You can't use Medicaid money for air conditioners unless you have a 1915 I waiver. You can use Medicaid money to buy an air conditioner, and as long as you keep track of the receipt, that gets counted towards your global budget. And if you save money by keeping people out of the hospital, you can reprogram that into starting food trucks that go to neighborhoods that are food deserts, or pay for people's gym memberships. All these things that are just like historically heretical to spend on Medicaid, a global budget allows you to do. So Oregon has cracked through the glass of all this CPT and HIC code funny business and basically said, hey, it's about improving the health of the population and better managing the costs and not just paying for medical services that you can count with a CPT or HIC code. Yeah, so it's scaling up wraparound. Yeah. So what's really cool about this is our federal government, the Centers for Medicare and Medicaid that has all these fraud auditors, has officially sanctioned scaling up of wraparound. Yeah, exactly. So this is the future. Okay, so the future, the reason why I wasn't saying tomorrow you're going to go to global budgets is because I don't think California will go there next. I think they'll probably go to capitation rates. But the maybe not long after that is the global budget model. So let's see. My gosh. What do all these states have in common is the last slide in this chapter. And we made it out alive. Moving from payment for volume, counting widgets and paying fee-for-service, to paying for value that I'll define in just a couple minutes. They're focusing on using payment models to improve outcomes. I'll explain more about what I mean by case rates and subcapitation and how that improves outcomes, with the goal of achieving the triple aim. So let's see. I'm just going to let you spontaneously combust and ask questions rather than pausing here. Oh, let's see. Would everybody do me a favor and stand up for just a second? Would you? I'll tell you why in just a minute. But would everyone just please stand up? And if you want to stretch in place like this, that counts. So while you're standing, how many of you have read the articles about sitting is the new smoking? Yeah, Brad, have you read those articles? What they found is that a sedentary, like sitting in an office for 6 to 8 hours a day, will shorten your lifespan as much as smoking. Oh my gosh, did you know that? And so I feel like, I'm killing all of you by having you sit here this whole time. So one of the things that we need to use this global budget money for are treadmill desks throughout the system. So feel free to sit down whenever you want, but
Dale, that's the least of the way that the killing is. It's made it in the news.
yeah. Google sitting is the new smoking. Yeah. That's because they have their backs turned.
So in California, we understand fee-for-service, progress notes, billing, all that sort of thing. In these other systems, how do you do oversight to make sure that you've got medical necessity or that your monies are going to the client's better health outcomes? How do you oversee these different structures for
Yeah.
so that you don't get in the situation like Washington got into where you were
Busted.
right?
Yeah. So what he said was, in California we know about progress notes and medical necessity and the golden thread of the assessment and treatment plan and progress notes all need to connect together and then they turn into a bill. The golden thread stays in place. So you still got to have the assessment that connects to the treatment plan and the progress notes connect to the goals in the treatment plan. So you still got to have that in place. The deal is that the money flows more flexibly so that if you bought that air conditioner for an elderly person, you would need to put that in the chart and you need to keep the receipt. So it's not terribly great at paperwork reduction, but it's great at flexibility. That's the difference. And I'll say more when I do some of these next slides. So let's see, 2 types of payment reforms. Value-based purchasing, which I'll define, and value-based benefit design. And this is kind of fun. So there are very few Medicaid programs that do value-based benefit design, but it's a really cool idea, and I'll explain that in just a couple of minutes. But let's relatively quickly go through this. So these are some of the payment models that we're seeing unfold. The first is a 3-layer payment model that's built on fee-for-service. So it doesn't throw out fee-for-service, it builds on it. What happens in the healthcare homes, patient-centered medical homes are doing this first, where they pay the fee-for-service for the CPT and HCPC codes, but then they pay a case rate for things like prevention, early intervention, care management, chronic medical conditions. So here's what they do. So pretend like I'm a patient-centered medical home in California that's on this 3-layer payment model. I'll still bill with my CPT and HCPC codes or my prospective payment system per encounter payment, but then I'll get a case rate, which is a per payment per person per month who I serve, to fund the stuff that doesn't get covered by CPT and HCPC codes. It includes consultation between providers and things like that. And then the case rate will allow me to hire more people to do the cool stuff that I can't get them to do enough CPT and HCPC codes for because they're doing cool stuff. And it pays for that without having to worry about CPT and HCPC codes. And then if I save money, if I lower the total healthcare expenditures for the patients I see, I get a bonus. And the bonus is often like half of the savings. So if I keep people out of the hospital, so the model is I pay fee for service, I get paid fee for service, I get a case rate layer, and if I use that money to become a hospital and emergency room prevention organization and I save the system money, then I get part of that savings that I get to reinvest in the system through higher salaries or more cool services or whatever. So this is one of the new, this is the transition, it's called a transitional payment model on the way away from fee-for-service. Here's what we're doing in Portland, Oregon. We're creating a case rate model for the mental health system. We hope to bring this to the drug and alcohol system. And what we've done, and this kind of gets to the last question, we have level A, B, C, and D. And what we're going to, and A is low. We've actually changed this into level A, B, C, D, and E, but I don't know why I said that because it's just confusing. But we're basically have low, medium, and high, and really high. And we have definition, so we have a level of care system. We're using the locus and the Cal locus, I know some of you use that, to assign people to the low, medium, high, and really high. And what happens is, like if each of you worked at a different organization and each of you had 100 clients with different mixes of low, mediums, and high, I'm going to write you a check each month for a lower check for low folks, a medium-sized check for medium folks, a higher check for high folks, and a really high check for the higher folks. And I'm going to pay you, not after you've submitted the claims, but I'm going to pay you basically, it's called a bundled payment for the clients that you have in care. And generally paid in monthly increments at different payment levels, lower payments for lower, I already said that. And each level payment represents the average utilization and cost for clients at that level. So maybe 10 hours worth of care for an episode of care for the low, and 50 for a medium, and 100 hours for high, or something like that. And then I'm going to have a performance measure and bonus system that's part of the plan. So the providers in Portland, 3 counties around Portland, are moving from what you know and love well, which is fee for service, to case rates, where that check is, and the deal is that you can use the payments, there's more flexibility with the payments, but we're going to keep track of how much service you provide so that if I give you $2,000 and you only provide $1,000 for the service, there will be a thing called a risk corridor where you have to pay some of it back. So you just can't take the money and run. So bundled payments is the future of healthcare. Yeah, Harriet's nodding because we did that in King County when she was running the King County mental health system. So King County, where Harriet comes from, has the longest running case rate system in the country in Seattle that's been going since like 1994. And they do this. And so I'm expecting that there's going to be some, maybe a small number of some, maybe a large number of some counties that as capitation rates kick in, move away from fee-for-service to case rates. So this may be a very big deal for your future, is moving away from paying for Valium to paying a more flexible pot of money that people can use in the kind of way that I was talking about Montana's 1915 I waiver. And as long as, and you have more protection from getting busted by the feds when you use case rates than when you're on fee-for-service, even if you don't have a global waiver or 1915I. And here are some of the incentive things that were, so let me describe to you, I'll describe what the incentives are and then how they're going to be folded into the system. So if you, I'm going to pretend like you're providers. So if you have a client that goes into the hospital and you go to see that person while they're in the hospital, that's going to be a click towards helping you towards a bonus payment. And also, more than just the hospital, you can see if somebody comes out of the hospital and you provide a psychiatry appointment within 30 days, you get another click towards a bonus. If we're in a community where there aren't enough the penetration rate's too low, there's not enough clients being served, we will give you a bonus if you see new clients. Not related, we'll pay you also for seeing them. This is the bonus for getting them into the system. There's this thing called initiation and engagement that San Mateo's been tracking for a long time, and we'll give you an additional payment for, here's the deal. There's this term called how many people have heard the term initiation engagement? Oh, great. So more than one of you. So initiation and engagement into care. If you have a serious disorder, there's a set of diagnoses that are tied to this. So Dale comes into your clinic. The first visit is called the index visit. If I get a second visit within 15 days, that's a good thing. And if I get a third and fourth visit within 30 days after the second visit, am I confusing you yet? 4 visits within basically 45 days, then there's a pretty good bet that I will have initiated care and engaged in care. Now, there's nothing that says that I really engaged in care, but the fact that I didn't go running, screaming away, and came back for a third and fourth visit is a process indicator that you can analyze. So we've pulled the data from San Mateo and we've run these reports. And the idea is if you have a lot of folks with SMI and SMI, a lot of kids with a serious emotional disturbance, and you're able to initiate and engage care, we'll give you a bonus. This is the payer. This is the health plan. Oh, this is what we're looking at in Portland, Oregon, as one of the bonus models. Yeah, and so because here's what managed care companies do now. They say, we expect people to have their first visit within 14 days, if it's a routine visit of when they called for service. But then if you ask the question, well, how long did it take till they had a second visit? People go, whoa, well, we don't talk about that around here, because everybody's full and it's not for 90 days. And so, anyways, this is a way to deal with that, incentivize that, and then also a bonus payment for each individual whose treatment is augmented by the regular use of an approved outcome measure. So here's I think that's all of them. No, one more. Bonus payment to routine organizations, providers who refer appropriately to peer service organizations or internal peer support specialists. Everything on this list, there's a hypothesis or a proven track record that if a provider does this, you will, let's see, well, one way of saying it is you'll have lower dropout rates, higher graduation rates, shorter lengths of stay, and better outcomes, and you'll save money. So the hypothesis here is that if we identify the outcome measures that do all those things, including saving money, we'll give you a bonus. So value-based purchasing is generally we pay something other than just straight fee for service, and we have a bonus arrangement so that you'll be incentivized to do the right thing, and that's value-based purchasing. and you can pay case rate or subcapitation or fee for service with some other layers added. And that's what people are doing in healthcare. It's sort of like money, let's see, money is a great motivator. What's the term? Money speaks. If you want to get something done, you give people money. I mean, follow the money. Money is the root of all evil. Why do we have money anyways? Okay. I'm not going to go into these other strategies because I want to get to the next chapter before we turn into a pumpkin. Okay, I'm going to completely shift gears, believe it or not, even though it sounds the same. So value-based benefit design is where you focus on the patient financial incentives and disincentives, not how the provider is paid. So, like right now, if you gave financial incentives to patients with Medicare money, you'd probably go to jail. Is that right? Isn't there some big prohibitions against that? So in the rest of the world, this value-based insurance design or benefit design is really alive and well. And the goal to influence individual consumers to make informed choice at many levels. So hey, do you know about this field called behavioral economics? Did you know that there are people called behavioral economists out there? What they do all the time is they figure out what kind of incentive I can put out there to change behavior. And so there's all these great studies that they do. So they have these biometric devices in homes for people who have diabetes or heart disease, and you do your blood pressure, you do your blood sugar, and it automatically transmits the data to the clinic. And if the numbers are wonky or wacky, then the nurse care manager calls you or comes visits you. You know how that stuff is playing out, right? But the weak link, if you will, is people, human beings, aren't always great at following through on doing their blood pressure every day. So what these behavioral economists do is figure out what kind of payment I can give to people so that they'll be motivated to do their blood pressure every day. And they actually give them a check. They give them money. Have any of you experimented with those kind of incentives for folks? Yeah? And with federal grant? Yeah. Drug courts. Yeah. So what I'm suggesting is that the future of healthcare payment reform includes these things. It's called value-based. There's another part of value-based benefit design, but incentives to live a healthy lifestyle, to seek preventative services and care when sick, to share in and make the right treatment decisions, to actively engage in your care, especially self-management activities, to select a provider that can help you achieve and maintain wellness. We'll give you something. So the woman, we had a conference on health reform in Washington a few weeks ago. The woman who used to be the head of human resources for Microsoft. Anyone ever hear Microsoft? I know down here you don't talk about Microsoft. But anyways, she's gone to work for this Oklahoma City-based company. And here's what they do. I go in to see my doctor. The doctor sees me and says, Dale, hello. Your 7 minutes are up. Sorry we didn't have time to talk about your problem. I leave, and the doctor then goes on, spends less than a minute going onto a website, puts in my patient ID and my diagnosis, and up comes a checklist, a list of patient education materials that are relevant to the visit that we just had. And the doctor checks what patient education materials that she wants me to read, and then sends. And what comes into my in-basket is a link to the patient education materials. And I go to this website. It's a proprietary website that these people in Oklahoma have developed. And I read the materials and I take a test. So why in the world would I want to waste my time going to a website and reading the materials and taking a test? They found that there's two reasons. One is that most of the patients, they've done a lot of research on this, they found that most of the patients want to be seen as relatively bright and educated when they're coming to their next visit with their doctor, and I'm going to get $15 for doing that. The doc gets $15, by the way, for spending that minute, and I get $15 for doing it and taking the test. And then what happens the next time I go in is we end up having a conversation. So it's not a 7-minute visit. We end up having a conversation about what's going on. And so there's a healthcare system in Central Washington called the Lourdes Health Care System, Lourdes. And they did this over 5 years. They were one of the research sites. They spent $257,000 on this for their employees. And they saved $3.2 million in healthcare costs for their employees. They had these really smart medical economists who were tracking this stuff. That's value-based benefit design. And it's the brave new world that's like, there's all these venture capital companies that are working on this. And so I would suggest that this needs to be part of the Medi-Cal design of the future. Let's see. Here's another thing. Here's sort of the good news, bad news story. So I'm sure this doesn't happen with any of you, developed in response to problems related to increased co-payments implemented by employers and insurance companies to save money. Has that happened in any of your workplaces where the co-payments have been increased? Well, what they found is that employers just increase the co-pays on things like diabetes drugs, cholesterol medicine, and blood pressure medicine. Okay, you tracking me here? Diabetes medicine, cholesterol medicine, and blood pressure medicine. And what they found, when patient co-pays were doubled, patients took less medication. Is anyone shocked yet? In important classes, these reductions in medication levels were profound. Reductions in medication supplied were also noted for these other things. For patients taking medications for asthma, diabetes, gastric disorders, there was a 17% increase in annual emergency room visits and 10% increase in hospital stays. Okay, so here's the deal. So value-based insurance design is also about making sure that if you do have, like Medicaid is talking about co-pays. I'm not saying Medi-Cal, I'm saying Medicaid. There's going to be much more flexibility for Medicaid systems around the country to do co-pays. And if you do what the private insurance companies are doing, you're going to have higher emergency room visits and higher inpatient utilization if you do it wrong. And so value-based insurance design is you make sure not to have co-pays on things that you want people to be taking, right? You want to do the opposite and give them a bonus. So on the mental health design, let's see, I'm going to just get back to this because I already said this. Here's another thing where you go in and you do, you rate the performance of your doctor visit. Do you think your doctor is treating you correctly? Are you satisfied with your doctor's care? This is a questionnaire that one of the companies has put together that if you do this, you get a payment for it. So doctor satisfaction. Now, what does this have to do with the mental health substance use safety net populations that don't have money and can't afford co-pays? It's going to be about education and financial incentives if you haven't figured that out. It's a really big deal. My neighborhood mental health center is thinking about the following. I don't know if any of you have done this. They want to identify, in every person's care plan, they want to identify, they're working on identifying, and this is part of what they're doing with a lot of their folks, recovery milestones. And every time a client hits a recovery milestone, they'll make a deposit into a recovery fund that's a bank account for the person that they can use for whatever they want, to buy a camera, to buy a guitar, to get their violin fixed. And so they're really thinking about this for their clients that have a serious mental illness in the form of a recovery fund. So anyways, enough of that. I hope that you see that it's not just about how to pay the providers, but the financing payment models are also about much more of a client-centered approach as well through the value-based benefit design. Any questions or comments before we go into the last chapter where I go into the real numbers and totally put you out of your misery? Yes?
What is the reporting mechanisms that are associated with these plans and payments? Federal government.
Oh, what are the reporting mechanisms? So for Oregon, there's still, the CMS gave them approval. What are the reporting mechanisms for these alternate payment models? CMS gave them the approval to do this, and they still haven't finished the reporting mechanisms. But CMS has said as long as you keep track of a receipt for the air conditioner and you put it on a report that will go called your global budget report, where you certify that this is the money that I spent. I really did spend it on things that were helping people move towards health, then it's basically signing your tax return, yes, I didn't lie to you and I didn't fake receipts. That's where they're headed. It's really interesting. When you're moving away from fee-for-service, you're not, you know, it's like the money isn't tied to the service I provided, so you can't, like if you audit someone and you say, well, you didn't, you had in your encounter data that you provided the service, but there's no chart note. How do I bust you if I didn't pay you for that service? There's one of my clients in Central Oregon, I won't say who just got busted by the Medicaid auditor in the state because they didn't have that golden thread of all chart notes for all the encounters that they provided. I shouldn't be saying this now. But they're paid on a sub-capitation basis, and the auditor doesn't know how much to bust them for. So it's an interesting dilemma that the actuaries haven't figured out yet. Yes, another question.
Well, just speak loud. We mentioned health homes, and it was reported in our local newspaper that our FQHC just got approved, certified as a health home. I can't find anywhere where a behavioral health provider can get some kind of certification.
Oh.
Maybe a little off topic.
No, I love your question. So the comment was, our FQHC got, I'll add a couple more words, got certified by the National Committee for Quality Assurance as a patient-centered medical home, and they're going to get all sorts of great bonuses because of that. But I haven't seen anywhere where there's a way for a mental health center to get certified as a patient-centered medical home. So there is no such thing yet. And there are 3 Republican senators and 6 Democratic senators, including anyone here, Marco Rubio? Does that name ring any bells? He's one of the co-sponsors of the Excellence in Mental Health Act. Do people know about the Excellence in Mental Health Act that just has been reintroduced in Congress? And the Excellence in Mental Health Act, this is kind of like, it's sort of related to your question, but gives me an opportunity to say something about it, is a brand new piece of legislation that may actually get passed this year that creates something that's never existed before, which is a federally qualified behavioral health center, or an FQBHC. It's something that I've been working on for 5 years now. We have FQHCs, federally qualified health centers, that you have to, it's not patient-centered medical home you get certified for, you get certified or appointed or pass the hoops to become an FQHC or an FQHC lookalike that you've been talking about a lot around your integration efforts. This new entity would create a parallel construct in behavioral health that would create a federally qualified behavioral health center that basically becomes kind of a good housekeeping seal of approval. We're working on trying to develop a definition of a behavioral center of excellence. LA is helping us, thank you, Bill, to start working on a definition of what that would look like so that we create our own standard, industry-wide standard that's blessed by the federal government as opposed to NCQA. So if you haven't heard about that yet, it may actually happen this year.
Anyway, thank you, Dale. I was curious about Oregon. I'm assuming that in the package of services provided includes acute inpatient service. Am I correct or am I
Oh,
not?
okay, thanks for asking that question. So there's two answers to that question. The phase one of case rates are for outpatient services. And so like if you were a provider and I came to you, you'd get a case rate to provide the planned care package for me. That doesn't include crisis, it doesn't include inpatient, it doesn't include other kinds of ancillary things. There's a defined package of what's included in the case rate, and it's just the community-based services that are in the care plan. Now there's one of the proof of concept projects that is going on there is to have a second case rate that would be the full meal deal for the 100 most expensive clients at the largest mental health center in Portland who said, give me what it costs, take everything we spend on inpatient psychiatry, crisis services, outpatient care, which is going to be way bigger than the outpatient case rate. Give me that case rate, and I'll be at risk for the inpatient. So that's most organizations can't handle that much risk. And so most organizations wouldn't go there, but we would like to try a proof of concept around that.
And then the last question is, sort of similarly, the Michigan and Montana service package. Does that include inpatient, acute inpatient?
Yeah, so in that case, the state pays a payment to the health plans that includes everything related to mental health and substance use, inpatient, outpatient, crisis, PUF, the whole 9 yards. But then, depending on how in Michigan, they subcapitate a lot of the providers. Subcapitation means pushing all that risk onto the providers. And so there's a number of providers in Michigan that are at risk for all that too, and they end up having to pay for, if more people go in the hospital, psych inpatient than were anticipated, then they take it on the chin.
All right, and then the last one, do any of the 3 states include state hospitalization service?
I can't remember about Michigan. In Washington, what happens is there's a quota, a target. You can only have so many people in the state hospital, and if you have more people in the state hospital than that, you pay for it. And if you have fewer people, and if other people are paying penalties for their targets, the bonus gets distributed among the people who have less people in the state hospital. That's how it works in Michigan, and I'm not sure about the other places. But generally, we've wanted to include the state hospital costs into the pot because otherwise you have a silo with perverse incentives.
Thank you.
So, gosh, you people are so amazingly good-natured and kind to put up with me talking about. I've been talking at you for like 6 hours now. Doesn't it feel that way? So we'll just have a little bit more, and then I'll.
Dale, I think all of us can each get a suitcase.
Yeah. Okay. All of you get a suitcase. Okay. So I saved the best for last. So let's see. Yeah.
You mentioned that the drug Medi-Cal is broken in the state of California. I haven't heard your suggestion of fixing it.
Oh. Okay. So. Wow. What a great question. Okay. So you happen to live in the state where Kaiser Northern California decided to pay for their Medi-Cal enrollees to pay for their substance use treatment, to give them a substance use benefit, even if Medi-Cal or the employer didn't, because their total healthcare expenditures are less, right? So Connie Weisner, she came to the CADPAC conference a couple years ago and said, I just did a study, and it shows that if you provide substance use benefits to folks, their total health care costs, including the substance use costs, are less. Wow, that's like an amazing thing, you know. And of course, she also said that the family members of the people, the kids and the spouses of the person with the substance use benefit, their costs their health care costs are higher than folks where the spouse doesn't have a substance use disorder. And if you treat the spouse, the family member's costs come back to average. It's like, oh my goodness. It's like, let's see, I'm not going to say that. So my solution is you do what they did in Washington State, which I haven't talked about yet, which is you adequately fund substance use treatment, a full benefit. You make sure that the people that are providing substance use treatment are connected at the hip with healthcare providers, either by creating the kind of behavioral health care homes that they did in Missouri or something else, integrate the care so that they're just not treating their substance use disorder and ignoring their metabolic disorder and everything else. And then you study the heck out of it to test the theory of whether a full substance use benefit will indeed bring down the total healthcare expenditures or not. And if you do it right, they will. And so my advice for California is there's enormous amounts of research out there that says if you adequately fund substance use treatment, you will bring down total health care expenditures, including the extra costs for substance use. You take the risk of doing that, but you make sure that the delivery system is connected at the hip with the medical care system before you turn the switch on. It's like, for me, it's like a no-brainer that you would save a lot more money than what you would spend on it.
Just as a point of information, Partnership Health, which is a seven-county consortium, is doing that. They're not covering anything that's covered by Drug Medi-Cal, but they have added in just as part of their basic benefit, and they're contracting with our local behavioral health department to provide services.
Where are you at?
Lake County.
Yeah, so when I was in Marin last year, they had they were just on the cusp of putting out a report. They're showing that they're saving money. That's right. Thank you. The Partnership Health, they're showing that they're saving money by doing that. It's like the state needs to get with the program. It's easy for me to say that because I can go home to Seattle and there's no retribution that will be put on me. Okay, great. So there's just a couple things that I want to say. Let's see. I'm going to skip this stuff because I'm going to put together a paper for Sandra. She doesn't know this yet. That talks about this, but I'm going to tell everyone not to read it right after lunch, because it's a little. I want to point out a couple things. That if you look, this is called the risk triangle, and the deal is that if you pay fee for service. Okay, so I'm a provider, and you're all the payers, and you're going to pay me fee for service. The only risk that I have is risk number. If you follow the discounted fee for service line across where it says to cost risk, the only risk that I have is if my costs are higher than what you're paying me, then I could lose money. But when you move to case rates and subcapitation, the payer is pushing risk and reward, is sharing the risk with the provider. And I want to spend a couple minutes showing you what I mean by this. So let's see. I'm going to skip this because the pictures are worth 1,000 words. So let's say that I'm paying you $125. I did a calculation and I thought I should pay you $125, and your costs are $130. This is like anyone who works in short-term Medi-Cal will understand this. There's a $5 per hour loss, and if you provided 10 cases at 20 hours, in 10 cases at 50 hours, we're getting close to looking at case rates, you would provide 700 hours, and my gosh, I provided 700 hours of service, I lost $5 per hour, I lost $3,500. Okay, so that's simple. But the opposite is if you were able to provide the service for $120, you saved $3,500. So that's like $5 times 700 hours. I either lose money or make money because my costs were $5 more, $5 less. But let's shift to case rates where it gets really interesting. So in this case, I built a case rate that is, okay, so now you're the providers and I'm the payer. And I built a case rate that assumed 20 hours for the low and 50 hours for the high level, just low and high. But you really spent 24 hours, not 20, and you spent 55 hours, not 50. You see that? So $4 extra for the low, $5 extra for the high. But guess what? I paid you a case rate based on $125 times 20 hours for the low, and $125 times 50 hours for the high. And let's just say that your costs were indeed $125 an hour. You provided, because there were 20 cases, you provided 90 extra service hours. And so 90 extra service hours times $125 an hour, you lost money. So, and on the other side, if you provided 4 and 5 hours less service, but were able to hit the performance measures, you made money. So this is the key math problem around case rates. I, as the payer, am paying you a pot of money. I'm saying you have more flexibility, but also if you're not carefully tracking how much service you're providing, you could provide more service than is embedded in the math problem, because the case rate is just hours times a rate. You could have provided more service than what I paid you for, and you would lose money. Or vice versa, if you manage properly and you're able to hit your outcomes and provide less service, it's a bonus. So a case rate model creates an opportunity for a risk and reward equation where you're incentivizing the providers to do efficient care, and if they do a good job and they haven't burned through all the hours, the rest is a bonus. And if they hit their outcomes, that's great, because I've incentivized efficient care. This is like really important. This is the sweet spot this is the CPA's version of how to get excited about case rates. You know, I'm giving you a pot of money. So it's like the cash register isn't chinging up and you keep billing services and saying, I mean, I'm paying you. What happens is you treat a person and you can have flexibility to the money with the money more than with the fee-for-service, and you do good things and you hit outcomes, and like the client wins, the payer wins, and the provider wins if you manage properly. Now, I use the term risk corridor. If you provided only half as much care, or 60% as much care, I'm going to have a risk corridor, and I'm going to make you pay some of that back, because unless you can build a really strong case that you did great things for the client, I'm going to assume you took the money and run. So you need to have a governor in the system as the payer. So is anyone else seeing the sort of elegance and beauty of how the incentives get realigned in a case rate model, or am I the only one who's like totally falling over myself? Harriet?
So it seems like the important variable in there is that you can't just do a case rate separately from making sure that the provider and the clients meet outcome measures.
Yeah.
Because otherwise the incentive is to underserve.
You can't just do a case rate without performance measures, because the incentive is to underserve. Yeah, did you want to finish your sentence? No. Yeah, that's right. And so remember those 6 performance measures I point out in the Oregon system? There's actually a much longer list, and we're still working on which ones we're going to use. But people, and there's a whole other conversation about that I wish I had time to go into, but I won't. But yeah. So actually, there's a similar math problem about capitation, but this is really where I want to leave you with is there's this little deceptive CPA sort of math algorithm that creates, when you really pull apart the case rate, if you're not managing it well as a provider, you have the risk of providing too many services, as well as having your services cost more. There's 2 types of risks you can lose money on, but there's the incentive to earn a bonus simply by having a case rate system, as long as you have a good performance measurement system in place. So with that, I'm going to stop and field a couple more questions, and then it'd be great if we ended at least a couple minutes early. We're supposed to go till, we said we had till 3:15, but that seems really cruel. Yeah.
Can we go back? Can you just keep it on that triangle slide while you're at it?
Sure. The risk triangle. Oops. I know, sorry. I pushed the... Okay. Any last questions? Yes?
My instincts tell me that small, I know small is relative, very small providers are going to be maybe not able to function in this world because they won't have the infrastructures that are needed.
Oh, yeah.
Small community-based organizations.
Yeah. So the question is, I'm afraid that small community-based providers won't have the infrastructure to manage this. Let's see. Couple things. In the new healthcare ecosystem, you need to be thinking about the whole health of your client. If you don't have the infrastructure and capabilities to think about the whole health of your clients, you're probably going to go out of business irregardless of the payment models. That's like Dale's only right half the time, so take that with a grain of salt. In King County, did you know that I'm only right half the time, my predictions? I know some of you know that. So you got to filter everything I say with, is this the time Dale's saying, is this the time he's right or the time he's wrong, because it's good flipping a coin. In King County, the small providers have done great. The small providers have done just as well as the big providers. And because when you have a level of care system where you're paying low amounts for low, high, medium amounts for me, high amounts for high, the providers are generally getting enough money to pay for a care plan, irregardless of whether the organization is a small organization or a big organization. So I think that in the future, if you have a big organization that's how's the term go? You can do you're doing a gazillion different things and you're not being great at any of them. You know what I mean, the term, a jack of all trades and a master of none. That large organizations that are jack of all trades and a master of none are more vulnerable in the new healthcare ecosystem than small niche providers that are doing amazing work and producing great outcomes. That's my prediction. If you're a large provider that has several centers of excellence and you spin off the things that you're mediocre at, but you're still large, you're probably better off than a really small provider to weather the winds of change. But it's all about becoming a center of excellence, no matter how big or how small you are. Let's take one more question and then we'll shift.
Do you have any experience where the performance measure that people are looking at is actually moving people to a lower level of care, so that the incentive is set up that you get a bonus or some kind of incentive if you're able to move some of those people that are currently receiving services at a high level down to a medium or to a low level?
So is there a performance measure, have we seen any performance measures in place where they're incentivizing moving from people from higher levels to lower levels of care? I don't think I have, but here's I am totally all over what you just said. The Mental Health Center of Denver is one of the best mental health centers in the country in terms of this conversation that we're having about graduation and dropout rates and lower lengths of stay. And what they do is they have 5 levels of care, and they have this really great process where they graduate people from ACT to intensive case management to intensive outpatient. And they're having really great success with these graduation rates. And if they were in a case rate or even a fee-for-service model, I would absolutely want to incent. I think that's a really important thing to do, but it has to be based on graduation where there's not non-coerced graduation where the clinician and the client are jointly making the decision. Otherwise, people get moved down when they're not ready, and then they end up in the hospital. Thank you, everybody.